Hello, everyone. It is now 16 minutes after the hour, and we will reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it is extremely important each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. Thank you again to our speakers, and we look forward to your comments. Our first public speaker is Mrs. Erica DeWalt.
I'm Erica DeWalt, Director of Strategic Communications and Partnerships with Vaccinate Your Family. Thank you so much for the opportunity to speak today. As the committee continues to evaluate the COVID-19 vaccine for children, I wanted to share our board's thoughts around requiring the vaccine for school entry. As you may know, our co-founders, Rosalind Carter and Betty Bumpers, were instrumental in the passage of laws requiring vaccination for school entry back in the 1980s. Vaccinate Your Family continues to support school vaccine requirements that keep our children safe from deadly infectious diseases. While that primary series of vaccines ought to be completed by age 2, school requirements ensure that no children fell through the cracks of the healthcare system and could be caught up on needed vaccines prior to entering kindergarten. Traditionally, vaccines are not added to the requirements for daycare and school attendance until they have been on the market for an extended period of time. Childhood safety data for each vaccine on the recommended schedule helps ensure parental acceptance of vaccines. School and daycare requirements should be put in place as a final mile to ensure that children remain safe from deadly infectious diseases in their place of learning. There are several parameters that should be in place prior to considering vaccine requirements for school and daycare attendance. 1, high parental acceptance. 2, broad availability of the vaccine. 3, physician or provider support for the vaccine. 4, full licensure of the vaccine. 5, stable and adequate vaccine supply. 6, addition of the vaccine to immunization information systems, also known as registries. 7, adequate data to assure vaccine safety. 8, significant uptake in the recommended population, in this case children, to reduce the compliance burden on both schools and child care systems. 9, coverage for the vaccine and delivery in private health insurance plans. And finally, 10, for vaccines that are not federally funded already, sufficient funding to purchase the vaccine through the VSC program, Section 317 program, or a state program. While the data supporting the overall safety of COVID vaccines is well established, the multiple criteria typically in place prior to considering a school-based requirement have not yet been met. Therefore, Vaccinate Your Family is urging state legislators, governors, and health commissioners to first ensure that necessary parameters have been met prior to considering the addition of COVID-19 vaccinations for children to the list of requirements for school attendance. For a full statement, please visit our website at vaccinateyourfamily.org. Thank you so much for your time today.
Thank you for your comment. Our next public speaker is Corinne Jones.
Good afternoon. My name is Karen Jones, and I'm the President and CEO of the National Caucus and Center on Black Aging. NCBA has a 52-year history of working to improve the quality of life and health and well-being for older African Americans and other communities of color. I know this committee has many different and competing factors to consider when making the tough decisions on the use of vaccines, but I cannot help but use my time to express my disappointment in the committee's decision not to expand the age-based recommendation for pneumococcal vaccines to age 50 and older. CDC data shown at previous meetings confirmed that the recommendation for those over the age of 50 would not only be cost-effective, but help to bring equity to populations that historically have low immunization rates, namely the population my organization represents. I submitted a joint written comment for this meeting with Dr. Yanetta Cruz, who's the president of the National Hispanic Council on Aging, and we titled that comment, "When America Gets a Cold, Communities of Color Get Pneumonia." Yesterday's vote was an important opportunity to work towards ending the reality of this committee's mischance. As several voting and liaison members of this committee noted yesterday, individuals aged 50 to 64 will respond to the vaccine much better than someone over 65 who is experiencing advanced decline of the immune system. Further, it was noted that while we certainly need to take cost effectiveness into account, we also must support policies that are equitable and will ultimately reduce mortality and morbidity in diverse communities. The last point I will raise with you from yesterday's discussion, which I think was worth repeating, is a very real fact that while it is a nice idea that people in their 50s could live another 30 years and thus require a booster shot, many patients from Black and Brown communities will not live to 65 due to chronic conditions, environmental factors outside of their control, and the effects of a lifetime of inequitable care. Why wouldn't we offer them protection earlier in their lifespan when we will have a greater chance of strengthening their immune system before chronic conditions set in? ACIP's reluctance to make these vaccines available to as many Americans as possible is short-sighted and it sends a confusing message to the American public. Unfortunately, what's clear to me and to many of my counterparts who represent diverse communities that this decision does very little to improve health communities of color and addressing health disparities. Thank you very much.
Thank you so much for your comment. Next is Mr. Burton Eller. We don't see Mr. Eller on the line, so we will move to Mrs. Linda Raykoff.
Good afternoon. My name is Linda Raykoff, and I have a primary immune deficiency along with a predisposition to developing ARDS, which I've survived 5 times prior to the COVID years. So when the whole world inhaled in March 2020 because of a pandemic, I thought, welcome to my very scary world. My family goes to extraordinary lengths to keep me safe. I would like to know, as you deliberate vaccine protocols, where is the data on patients with primary immune deficiencies? I've been able to find just one study on vaccine response in patients with PID. I tried to enroll, but it was full and I was denied participation. So because I'm not in a study group at NIH or Johns Hopkins or other places, I've only ever gotten a yes or no answer on my lab test for antibodies to COVID. But I know from my own research that these tests exist. I know of multiple studies to determine numeric antibody levels in solid organ transplant patients. I know the NCI has a study on B and T cell response to COVID. Without minimizing those patient groups, I would like to know when the ACIP will have similar data for patients with PID. When will the test for the numeric level of antibody production after vaccination be widely available to the patient population I represent? And will our family members, those in our bubble, will they be able to get antibody levels tested? It seems that we can, but only if we know how or who to ask or where to look. Others in the autoimmune and PID community still have to argue with their pharmacists, doctors, and public health personnel just to get a 3rd dose, not a booster, which this committee recommended in late July or August. The language from this committee matters. How it is communicated to the public and to patient advocacy groups matters. I urge you to develop antibody testing guidance for those of us in the primary immune deficiency community and for our families. I urge you to allow our family members to get 3rd shots and booster shots outside of your guidelines presently. I encourage routine testing for the numbers, not just positive or negative emojis, because knowing the numeric level of antibodies I produce along with B and T cell response will help me decide when it's safe to go outside my house and exhale. Thank you for your time.
Thank you for your comment. Next is Dr. David Wiseman.
Thank you, Doctor. Can you hear me?
Yes, we can hear you. Please go ahead.
Thank you. I was a senior J&J scientist and have since received research fees outside of vaccines. I have received funding from Steve Kirsch and MathPrep. Please see our written comments. Thank you, ACIP and VRBPAC, for diligently wrestling difficult issues. But you are only as effective as the data presented to you and your understanding of how your words will be used to shape policy. FDA's Dr. Krauss chided Pfizer's withholding data from FDA. We suggested that waning immunity data were withheld from ACIP. Although advisory committee decisions are not binding, FDA and CDC have stretched recommendations on boosters. The distinctions between the Pfizer EUA and the Comirnaty BLA vaccines do not appear to have been explained to you and are increasingly blurred, including by CDC. The discussion of flu with the EUA Moderna vaccine yesterday opens a regulatory backdoor. A non-voting ACIP discussion about vaccines in pregnancy preceded a CDC health advisory, despite Comirnaty's labels saying that data are insufficient to inform pregnancy risks. Do pregnant women know that CDC has 2 studies where there is a, quote, urgent need to monitor the safety of these vaccines? Or do they know these studies requested informed consent or parental permission waivers? Pregnant women are effectively mandated to unknowingly participate in a medical experiment. Do you endorse this? The small and limited mix and match study, labeled preliminary in its medRxiv preprint version, was the subject of a VRBPAC non-voting discussion. But we now see FDA's ruling that mocks VRBPAC's intent, creating therapeutic chaos and a safety tracking nightmare. You appear unaware that these vaccines are classified by FDA as gene therapy products and what that means long term, and that Comirnaty has not been evaluated for carcinogenicity, genotoxicity, or effects on male fertility. Safety signals remain unaddressed. We show VAERS signals greater than for myocarditis, deaths 200 to 300 times higher compared with flu vaccines, coagulopathy 400 to 500 times for Pfizer and Moderna, and 1,400 for Janssen, and myocardial infarction 300 to 400 times. The case of boosting is largely based on small immunobridging studies with no established immune correlate for protection. It relies on Israeli data for efficacy where there are significant statistical concerns. And we're following primary or booster vaccination. The increase in severe cases precedes that for unvaccinated people, suggesting transmission issues. You are being asked to evaluate Janssen's safety and efficacy data that FDA has admitted it has not verified. It seems that every regulatory safeguard is being tossed out. America trusts you to follow the science and transcend politics. Your decisions have much broader consequences, such as mandates. Don't base decisions on extrapolations of improperly reviewed data. We urge you to challenge CDC and FDA and to demand answers. But thank you for your work. Thank you.
Thank you for your comment. We'll move on to Candace Johnson.
Good afternoon. My name is Candace Johnson. I'm a kidney transplant patient, a participant in the Johns Hopkins study for antibodies and TMB cells, and a member of the TRIPEG advocacy group. My message today is to strongly encourage the FDA and CDC to reconsider their guidance on antibody testing. Current data is based on information from July or earlier. Dr. Dorit Rice, Associate Vice Chair for Research, Professor of Surgery and Epidemiology at Johns Hopkins, wrote an article in The Hill this weekend that we have much better antibody tests now, and in listening this morning, vaccine studies on efficacy are based on antibody response. Labs are run on a routine basis to gauge health status. Why not add quantitative antibodies to the list? Without testing and collecting this data, especially on breakthrough infections, we'll never know how effective actual levels are. Dr. Segev's research has indicated that higher antibody levels neutralize more COVID than lower levels. So these tests clearly prove something. To quote his words, it's time to check antibodies and take the guesswork out of the pandemic. This is particularly critical for immunocompromised people. Quoting Dr. Segev again, vaccination does not necessarily mean strong immunity. I am a perfect example of that. With 3 doses of the Moderna vaccine on the Roche scale, my antibodies are less than 0.4%. I know I must double mask and social distance to keep myself and others as safe as possible. But what about others who may not have produced antibodies and don't know it? Using antibody test levels can give us an understanding of where we stand in terms of protection. Just as this panel is doing today, please consider regular testing so that we can make informed decisions, not measuring antibodies just flying by, blind. On yet another very important note, Our family members and caretakers continue to suffer along with us as we quarantine and do everything in our power to protect ourselves. I urge the FDA and CDC to include these individuals in the group of those eligible for booster shots so that they can not only protect themselves, but also protect us if they get COVID. Thank you for the opportunity to make these comments and for listening. Your diligence and your compassion is greatly appreciated. Thank you.
Thank you for your comment. Our next speaker is Laura Burns. Laura Burns. There you go. Okay.
My name is Laura Burns. I'm a double transplant recipient and a participant in 4 of the Johns Hopkins studies on vaccine efficacy among transplant recipients, led by Dr. Dorit Rice. I am also a member of TRAPAG. We urge you to adopt the Moderna and Janssen EUA changes announced by the FDA yesterday and to allow the mixing and matching of vaccines. At the last ACIP meeting, I asked you to specifically authorize boosters for our close contacts who form our bubble. Our members implore you to include them this time around and to address this issue in your discussion. As Dr. Walensky said, our job is to protect as many people as possible. We're also concerned by the use of the term booster for a second dose following the J&J. The FDA panel universally opined last week that this was in actuality a second priming dose, not a booster, because it brings vaccine efficacy from around 70% to over 90%, making it closer to the mRNAs. So they authorized it for everyone 18 and older, and after just 2 months. But what about the immunocompromised who had no response to the first J&J? We cannot assume they won't need 3 doses to be primed. And how are they to know whether they respond to a second dose? As a doctor, wouldn't you order an antibody test? In your decision-making, you have relied extensively on studies which measure antibodies as a proxy for vaccine efficacy. Shouldn't we? In written comment, I submitted the op-ed in The Hill by Dr. Segev, and that is called "It's Time to Check Antibodies and Take the Guesswork Out of This Pandemic." I urge you to read it. When you have a medical issue, doctors want labs which inform them as to your status. Not measuring antibodies is flying blind. We can no longer say we don't know what antibody levels mean. That might have been somewhat true in July, but it's not true now. We have a very good sense of what antibodies mean, that they correlate with neutralization and actual clinical protection. More and more studies are showing this. They're not perfect, but many tests done in clinical medicine aren't perfect. The way to use antibodies is to test them and incorporate them into the bigger picture of individualized patient counseling. Dr. Sanchez, you have often raised the question in past meetings, if we don't test for antibodies, how will we ever find the correlative protection? Indeed, how will we? So please, approve the Moderna and Janssen boosters, allow the immunocompromised who got J&J to get a third dose, as you did for the mRNA. It's a question of equity, and allow for a mix and match. I thank you very much for all your hard work and for your kind attention. Thank you.
Thank you for your comment. We see Mr. Burton Eller is on the line. Mr. Eller, would you like to go ahead and give your comment now? Okay, there seems to be a challenge with audio, so Mr. Eller, we will come back to you. Next is Miss Sarah Berry. Miss
Can you hear me?
Yes, we can. Thank you. Please go ahead.
Sorry, one moment. I have to, sorry. All right. Thank you to all of the ACIP for continuing to do critical work during this time. My name is Sarah Berry. I am an independent pro-vaccine advocate, and I am grateful for the opportunity to speak today. First, I would like to update you all on the status of anti-vaccine legislation in Ohio. I'm happy to report that HB 248, which was written and supported by Ohio's anti-vaccine lobbyists, is officially dead. As a reminder, HB 248 would have made it illegal for anybody to require any vaccine, not just the COVID vaccine. Attempts were made to create a new, more watered-down version of HB 248 called HB 435, but at this time, it appears that both bills are dead in the water. I would caution that although this is good news, anti-vaccine activists in Ohio still have a tight grip on the legislature, and I strongly believe that a heightened awareness of the political lobbying anti-vaxxers do all over the country is necessary to combat vaccine hesitancy and misinformation. Most recently, I obtained and provided to the Ohio Capitol Journal footage of Ohio Senator Andrew Brenner speaking to a group of anti-vaccination advocates about alternative treatments for COVID-19, one of whom suggested gargling diluted bleach as a preventative. Senator Brenner then shared that he will be introducing a bill that will prohibit discrimination, quote, against people or information that deals with alternative therapies, such as what you've been discussing today, unquote. I've talked before during ACIP public comment about how prior to the pandemic, the anti-vax community has allowed and sometimes explicitly endorsed abusive treatments and cures for autism, such as using bleach enemas or chelation. I strongly believe that if a forceful campaign against such abuse had been implemented prior to the pandemic, that we would not be in as bad of a position as we are in today. It is incumbent on all of us to recognize the outside influence anti-vaxxers have on our political landscape, and to realize that the trickle-down effects of ignoring that influence will lead to worse health outcomes for all people in this country. Yes, I have most certainly worked hard on my own to expose the anti-science and anti-vax sentiments within the Ohio legislature by working directly with reporters and journalists who will take me seriously. But there is nothing stopping you all as individuals from doing the same in your own communities. And I think that your position as being on ACIP will help lend credibility and not make it as hard for you to be taken seriously as it sometimes is for me. And if you need help with this, I do invite you to message me on Twitter at my handle 42believer. I will close my statement by sharing with you all the mental toll my advocacy has taken on me. As a visible pro-vaccine advocate, I have been subjected to online abuse by extremists such as the Proud Boys, and also what I worry are intentional efforts to intimidate me at my home. For many months now, there have been regular anti-vax protests across the street from where I live. Some days, the anxiety literally makes me throw up. I will not stop because we all know that this issue is that important. And I know that such abuse might make it hard to do this advocacy on your own, but I urge you, it is so important to take it seriously and to not let people strike you down and just continue your advocacy, and please continue having these important conversations. Thank you for your time.
Thank you for your comment. Next is Mark Gibbons.
Yes. Thank you for the opportunity to speak today. My name is Mark Gibbons. I'm a husband, a father, a veteran, and a man who has passed the demarcation line of mid-century birthday. I'm also the president of Retire Safe, a nonprofit advocacy organization giving voice to the concerns of older Americans. Health and healthcare, while always a major importance, now rank at the top list of concerns of virtually all adults, but especially those of us who are approaching Medicare and Social Security eligibility or are already enrolled. And it is to that reality I address my remarks. First, thank you for your tireless work that you have done this year. Surely, no year in history has been as complex or as important. I had hoped to be given a slot to speak yesterday before your vote on the new pneumonia vaccine, but our point remains the same. Those of us over 50 know we are vulnerable to flu, and that's why we get vaccinated each year. Please know our concern about how vulnerable we are to pneumonia as well. While it is true that the older one is, the higher rates of pneumonia are among our age group. People my age, 58, over 50, but under 65, are unfortunately well represented among a million of people who received hospitalization for pneumonia in any given year, and sadly among the 50K who die from it. We are vulnerable because many of us are beginning to have chronic illnesses that are not yet diagnosed, or don't have health insurance, or are genetically predisposed. Maybe it is because over 40% of us are overweight, a factor that many recent studies have linked to susceptibility to pneumonia, or because we smoke and we don't tell our doctor that we do. Whatever the reason, 65 is not a magic moment when we go from low risk to high. It's a continuum that advances. I'm not looking forward to telling our community of supporters that they may not yet be eligible for vaccines which can protect them from this dangerous disease. But on their behalf, I want to respectfully suggest that ACIP consider widening the margins of protection, not in several years, but much, much sooner. We need your help. Thank you.
Thank you so much for your comment. I'm going to call on Mr. Burton Eller. Mr. Eller, are you able to unmute? There we go.
Yes, can you hear me?
We can. Please go ahead.
I'm so sorry for the technical difficulties. Yes, my name is Burton Eller. I'm from the National Grange, the nation's oldest organization representing agricultural, rural, and small town life in America. Allow me to begin this with some harsh facts. In urban areas, most people live about 4 miles away from a hospital, but the distance is twice that in rural America. Lack of access to health care where we live accounts for 55% of what could be preventable hospitalizations or deaths. Rural life expectancy is 2 years shorter. Since 2015, 181 rural hospitals have shut their doors, and 1 out of every 4 that remain are struggling. Fewer healthcare providers and facilities, longer distances to obtain care or receive community services, lower wages, fewer unemployment opportunities, and less access to technology. These factors result in very serious healthcare concerns for rural Americans. We all had a very hard winter last winter, but the situation in rural America was already operating with significant disadvantages. No one solution will solve all these problems, but you can depend on Grange members and all rural Americans to do their part in climbing out. We do understand that prevention is a key factor in health security, and that is the major point we want to make today. Rural life has risk factors that may not show up in clinical studies, but nevertheless are very real. For example, just before COVID, the National Center for Health Statistics reported that the age-adjusted rates for influenza and pneumonia were higher in rural counties than in urban. We are worried as we enter this pneumonia and flu season this year. Hopefully COVID will continue to decline, but will there be significant twindemic of these other 2 dangerous diseases? If so, we already know that we will be placing catch-up from the start unless action is taken now. We thank ACIP for its work on pneumonia vaccines, though we had hoped that age 50 would have been the designation point to help get us on a jump start basis. We will do everything we can to make certain rural America knows what's available to them and why it is so important to protect themselves and their families. We will work with you in every way to our common goal. Thank you.
Thank you for your comment. Next speaker is Dorit Rice.
Can you hear me?
Yes, we can. Please go ahead.
Wonderful. My name is Dorit Rice, and I'm a professor of law in the University of California, Hastings College of the Law. Thank you again to the committee for all your hard, intensive work in these trying times. Today, I want to talk to you as someone who teaches administrative law and emphasize the need for explanation and transparency. I want to touch on 4 things. First, after your previous meeting, the CDC director changed from the committee's 4th recommendation. It's the job of the CDC director to decide, and she does not need to be a rubber stamp. But even when she deviates from the committee's recommendation, the public deserves to know why. I would urge the CDC director in future to clearly and openly set out reasons for deviating from any committee recommendation. She may have a more public-oriented point of view than the committee, more policy-oriented, but as in other administrative contexts, the public deserves to know the basis on which decisions are made, including why the director decided to deviate. The committee's deliberations are public. We heard thorough explanation from members. We need similar from the director. Second, the committee does not vote on explanations, but when you make recommendations about boosters and mix and match, the public will have questions. We're already hearing, following the FDA meeting, question on if the data is not clear about mix and match, why recommend a preference for the same vaccine? You have to make recommendations even in uncertainty, but the people implementing them are going to have to explain. Every year you put out immunization schedules, and in them you address, you give explanations. If the committee could consider adding short explanation to recommendations where the science is uncertain, I think it will be very helpful for people who have to put their recommendations into practice. Third, as mentioned by the previous speaker, we still have strong disparities in vaccine access. That's not your area. You do not control access, but the message from the committee is that if priorities need to be made, prioritizing bringing vaccines to people who have not received them, for example, vaccine clinics going to where people are, providing support to people who need time to get vaccines could be useful. And the statement that in providing additional doses, prioritizing neighborhoods and groups badly hit by the pandemic might also be helpful. And finally, I want to remind you, and I'm saying this with some sorrow because many oral comments are really helpful, that you do not have to legally provide oral comments, and that they have been used and will be used to create anti-vaccine propaganda and legitimize it as comments to the CDC. If you have a staff member summarize the major issues in written comments submitted 72 hours before a meeting, you may achieve more meaningful public participation by providing issues across commenters and maybe giving the committee a chance to consider them carefully. Thank you for your time.
Thank you for your comment. Our last speaker today is Dr. Kelly Moore. Dr. Moore?
Thank you, Dr. Lee. I'm Dr. Kelly Moore, the CEO of Immunize.org, also known as the Immunization Action Coalition. I'm a former ACIP member and the former chair and current member of the Viral Hepatitis Work Group. My comments relate to your upcoming hepatitis B policy considerations. There's been a lot of discussion about the relative merits of risk-based versus age-based adult vaccine recommendations. Some have asked for evidence that age-based recommendations work better. There's quite a bit of it. As my colleague LJ Tan noted yesterday, our risk-based pneumococcal vaccine recommendations are poorly implemented, with just over 23% of high-risk individuals vaccinated, while 69% of those subject to an age-based pneumococcal recommendation are vaccinated. We can also point to similar low coverage rates under the old influenza risk-based recommendations years ago set aside in favor of age-based recommendations, and to current risk-based adult Hep B and Hep A vaccine recommendations. Programmatically, unless risks are easily defined and obvious, risk-based recommendations for preventive interventions are weak solutions to population-wide problems. The current risk-based Hep B and pneumococcal recommendations favor those who are more highly educated, with advanced health literacy, no problems accessing medical care and advocating for their needs, and who have healthcare providers who find ways to incorporate vaccine risk screening in their practices. That is no way to deploy vaccines to address health disparities. Every person is at some degree of risk of hepatitis B infection that rises and falls over their lifetime. Of all the acute Hep B cases reported to CDC, only 1 in 3 reports a known risk factor. 2 out of 3 acute Hep B cases reported leave risk factor blank or indicate no risk factor present. Hep B vaccination provides lifelong protection, whether you choose to travel or develop diabetes or share a home with a person with hepatitis B, you're protected. That's why our age-based childhood vaccination program has been such a phenomenal success. We have set national hepatitis B elimination goals, but rates are rising in middle-aged adults. We cannot eliminate hepatitis B in the United States without a new approach. To make no change is the definition of insanity. If you define insanity as doing the same thing repeatedly and expecting a different result, you will hear that the work group discussed both an age-based adult recommendation with an upper age limit with risk-based above that age, as well as a simple universal adult recommendation. I can support either choice. What we cannot continue, and all of the work group agrees, is more of the same. Thank you.
Thank you for your comment. And with that, we have concluded the public comment session, and we will take a 5-minute break and be back at 55 minutes after the hour to begin the next set of presentations. Thanks, everyone.